Welcome back. Good afternoon, everybody, and thank you so much again for joining us for the 7th Annual International HIT Lab Innovators Summit. I am very, very excited to introduce our next keynote discussion, our keynote speech from Dr. Satchit Balsari. Dr. Balsari is an assistant professor in emergency medicine at Harvard Medical School and Beth Israel Deaconess Medical Center, and in global health and population at the Harvard Chen School of Public Health, where his research has contributed to advocacy on behalf of vulnerable populations affected by disasters and humanitarian crises. Dr. Balsari and his team recently published Every Body Counts, Measuring Mortality from the COVID-19 Pandemic. As of mid-August 2020, more than 170,000 US residents have died of the coronavirus disease. And although the true number of deaths resulting from COVID-19, both directly and indirectly, is likely to be much higher. The proper attribution of the deaths to this pandemic has a range of societal, legal, monetary, and public health consequences. Please join me in welcoming Dr. Satchit Balsari. Thank you so much for joining us here today.
Thank you, Justin. Am I audible?
Yes, you are. Sound good.
And you can see my screen, yes?
That's correct.
Great. Good afternoon, everyone. I would like to take this opportunity just to set a little bit of a narrative arc and background for the next 20 or 30 minutes. By way of introduction, in addition to what Justin said, my team has been working on the application of big data tools to pandemic response and planning. What I'd like to do is visit 4 key features of our pandemic response. Certainly morbidity, the number of COVID cases we've seen, with a quick look at the models and why they all seem to have been fairly suboptimal. Then at the mortality numbers, the crux of what Justin was talking about, and the difficulty with counting how many people have died or will die from COVID, the disease, from SARS-CoV-2 infection, as well as COVID-19, the pandemic. I would then like to visit digital contact tracing apps and again, sort of look at the same lens of who we're counting, who we're not, who's left behind, and why digital contact tracing apps, despite the heavy investment in them by the largest technology companies in the world, have not been very effective. And finally, we will look at mobility data, human mobility data that has been made widely available during this pandemic by technology companies from around the world in public-facing platforms. I will conclude with some of the work that our team has been doing to try and make the data we have been using for the pandemic more transparent, more readily available, by creating platforms on which a variety of researchers from various disciplines can plug and play as a possible solution to address some of the challenges we've been facing. These are 2 maps from 2 graphs from April, May, and June 2020. The one on the left is our morbidity in India, number of cases. The one on the right is mortality, the number of deaths in New York City. And you see that both have been very, very flawed. Certainly the number of cases in India has not petered off by June 2020. If anything, we have the 2nd largest number of cases anywhere in the world. The number of deaths haven't petered off by June either, as was predicted by several models from very reputed universities around. And this seems to have, certainly perplexed the lay public. There are lots of questions about why these models failed. If you remember, in March, April, and May, there were all these attempts for AI to predict what the next hotspot will be. There are tons of investment in this, and every computer scientist and data scientist that was good at modeling attempted to model these. The challenge with modeling this pandemic was the absence of the rich contextual information that was needed for each of these models. So let's look at what data goes into these models. These models were predicting, based on the number of tests that they were seeing, how the pandemic will progress, right? So to be able to predict what the shape of the curve is and to calculate the R0, something that all of us learned about early in the pandemic, you essentially, the base data that you needed was how many people are getting infected over a unit time, over unit space. how many people are getting infected is determined by the number of positive tests. Who was getting tested changed over time, but also from place to place. So let me give you an example of the medical hospitals affiliated to Harvard Medical School in the Longwood area. Early on, there were no tests. As soon as the tests arrived, we started testing everyone that was suspected of having COVID. Very soon, America ran out of Q-tips. If you remember, the wealthiest nation on earth could not produce enough nasopharyngeal swabs to test people. So there were very limited tests, and we actually stopped testing people who had COVID. If they would come to the emergency departments and they were not very sick, then we said, you, in the middle of this pandemic, have symptoms that suggest that you have COVID and should therefore go home and quarantine for 2 weeks. The tests were reserved only for those that were very, very sick to make sure that they did indeed have COVID and not something else that could be treated differently. In India, for the first several months, the government disallowed the testing of asymptomatic patients. Now, we know that the majority of patients who were exposed to COVID and who would get COVID were actually going to be asymptomatic. So the majority of people that had COVID in the early months, almost 4 or 5 months into the pandemic, were not allowed to get tests by national policy. So what you begin to see is a shifting denominator, a wildly asymmetric denominator across time and across space, across countries. The criteria for who was being tested changed. The criteria were not consistent. Even if the criteria were consistent, access to the test differed. In many countries, if you were positive, you were forced quarantined in public facilities outside your homes. And so there was fear and stigmatization around testing. And so you would not get tested. So you would miss all these people that may have had access to the test, but did not want to access the test. And then finally, what kind of test are you using? Is it an antigen test? Is it an antibody test? Is it an RT-PCR test? Because they all mean different things, and the sensitivity and specificity of each of these tests was very different. None of these models in the early months factored for this wide variation in the denominator. And very predictably, if you had sort of asked infectious disease epidemiologists, they would have pointed out that these models were going to fail miserably. The challenge we've had is that the right kind of expertise was not often at the decision table, where you had a lot of well-meaning, enthusiastic computer scientists and private sector players from the startup ecosystem that really wanted to sort of help community and leverage big data tools without either the deep expertise in infectious disease epi or the contextual intelligence around how the disease was going to be transmitted in the particular demography of the country that they were working on. I think one of the gravest errors early on was that everyone looked at Italy and Spain and saw the high mortality and applied those models to Asia, where the demography is completely different. The majority of Indians, for example, are in their 20s, and we're not going to die from COVID, but we're going to get sick and probably be asymptomatic and continue to spread the disease. India's elderly, for example, do not live in group homes. And sort of none of these nuances were factored into the early models. This becomes even more challenging when you start looking at deaths. We think of deaths after disasters in 2 categories: direct deaths, according to the definitions put forth by CDC and by international consensus. Direct deaths after disasters, or in the case of COVID, would be from COVID-19 infection. So people have COVID, their medical conditions get worse, or just the disease from SARS-CoV-2, the pathology that results in their lungs or in their bloodstream causes them to die. And those are direct deaths attributed to COVID. The CDC provides guidelines for how to document that a death is attributed to COVID. Typically in a death certificate anywhere in the world, what you first see on point A is the immediate pathophysiological cause that causes death. Usually COVID patients will die of some kind of respiratory distress or, respiratory cardiac failure. And it's almost always, in most cases, the first documented cause of death. The underlying cause can be pneumonia, and that could be as a consequence of COVID-19, right? So COVID-19 would really show up as C or D as one of the causes that led to the person to then have other complications and die. And unless COVID-19 is documented on the death certificate, the death is not considered a COVID-19 death. The difficulty with this approach early on is that we didn't know how to recognize COVID-19 deaths. The clinical definition kept changing. Our global understanding of COVID-19 was evolving, and there were more and more symptoms being added to it. Even if you suspected there was a death from COVID-19, tests were not available, and confirmation was not possible. The CDC, in fact, did say in the United States that you should document on the death certificate that the death was from suspected COVID, even if you did not have a lab-confirmed COVID test tagged to that patient. So early on, the deaths that you miss, which is the white strip, excess all-cause mortality, meaning all the deaths that occurred more than you would have expected for that time at that place. So you look at deaths for the last several years and say, in April, May, and June, I would roughly estimate these number of deaths. How many more deaths did I actually find? And early in the pandemic, you'd find that majority of these deaths are deaths directly attributed to COVID. However, we may not be picking up all those deaths because the clinical criteria were evolving and the number of tests were not available. But as you move on, the number of indirect deaths begins to rise. These are deaths from people staying at home because of the lockdowns, missing their critical appointments and falling very sick. Their asthma getting worse, them not having access to medications, coming to the emergency department and dying because they missed critical hours of days staying at home. People with diabetes with an infection that could have been treated in a timely fashion with antibiotics now have gangrene and die a month later. The heart attack that may have otherwise come in but stays at home because you're worried about going to the hospital in the middle of the surge. You think it's just gas and try and take Tums, but then the patient dies. These indirect deaths are not, there's nothing particularly unusual about counting indirect deaths. We have always done it after disasters. Direct deaths after a hurricane or a flood would be from the collapse of a bridge or a collapse of a house or one drowning. But if the road collapses and you cannot get to the hospital and you stay at home and you die, that is considered an indirect death. The CDC, in fact, has a very low bar for considering deaths, indirect deaths from disasters. It suggests that you apply the what if test. What if the COVID pandemic was not going on? Would this patient be alive? And that means that hundreds of thousands of people that have lost their wages and that may have lost their health insurance, who lose access to care, may actually develop worsening comorbidities that might contribute to mortality downstream. This is a hard question, of course, because then when do you stop counting? Is it, deaths 6 months from now, 9 months from now? Folks have attempted to model this, and these kinds of delays in diagnosis during the COVID pandemic is likely to have an effect on cancer deaths, but more downstream. Because it is really challenging to attribute an indirect death to COVID-19, what scientists therefore do is calculate excess all-cause mortality. In 2020, we will look back and say how many more people died than we would have expected in 2020, and all of those will all under the curve that you see under the dotted lines would be considered the excess mortality from the pandemic. Some of whom, or the majority of whom, would be direct deaths. Many would be indirect deaths, and the white band would be a combination of direct and indirect deaths. We just will never know where they actually fall because of incomplete data. The question, of course, is if this is so hard and complicated and resource consuming, why do it? It's extremely important to do it. Early in the pandemic, you want to know not only how many are dying, but who is dying, because it helps us, especially with new diseases, to understand the pathophysiology and the risk factors. By March or April, we had a good sense of who was dying. We knew that children were safe. We knew that the elderly were really unsafe and that they needed to be protected, that people with comorbidities, with diabetes, with hypertension, with other diseases were going to be particularly vulnerable and they needed to be protected. Moving on, as we sort of go into month 6, 7th, 8th, 9th, year 2 of the pandemic, it's really important to have access to this information about mortality because it sheds light on the social determinants of disease. Where are these indirect deaths coming from? Who were the people that were most affected that may not have gotten infection from COVID, but continue to die because they had less access to healthcare than other people? They had other vulnerabilities. And studies have already shown that the impact of COVID has been very differential across the socioeconomic strata around the world. The poor, the infirm, those without insurance, those with comorbidities have been particularly affected. Minorities with baseline limited access to care are likely to be the ones that will constitute a majority of the indirect deaths. It's also important for closure. When excess mortality was calculated by colleagues from Harvard in the aftermath of Hurricane Maria in Puerto Rico, where studies showed that there were about 4,000 excess deaths after the hurricane, and not just 57 as was initially attributed by the federal government. It was an extremely important and cathartic moment for the community as well. And they felt that society was finally acknowledging the loss that they had suffered. I'm going to shift gears here, but feel free to ask questions in the chat, and we'll leave some time at the end to take questions. Digital contact tracing apps were touted as the panacea in several countries early in the pandemic. Contact tracing is important in early stages of the pandemic. You want to try and find all the individuals that have the infection and then trace all their contacts, people that they have come in touch with, and test them, quarantine them, isolate them if they're positive to prevent the spread of infection. This is fairly standard, and it was last done at a large scale during the Ebola pandemic. The international community had contributed to it. You would go house to house to interview people, to inquire who they might have come in contact with, who they may have exposed. And then you go to those people and see who they would have come in contact with. Except with the COVID pandemic and the scale with which it was ravaging cities around the world, densely populated cities, it was very clear that manual contact tracing was not going to fly. And that it would be really important to use technology to augment what would have been sort of boots in the ground contact tracing. And therefore, technology companies stepped up, startups stepped up, governments were very keen on trying this, especially after the early success in South Korea, to some extent in China and Singapore, to develop contact tracing apps. The models have been very different, some highly centralized, where the government, public health agencies turn on your app and report your infection status. So if you've tested positive, your app marks you as positive, and the phone, based on all the other phones that you have been in proximity of over the last several days, the criteria most widely used was 6 feet and 15 minutes. So if your phone was next to another phone for 6 feet and 15 minutes, you were assumed to have exposed each other. And if your status turns positive, then all the contacts that have been logged on your phone are pushed to the government server, and the Central Public Health Agency will contact everyone that was exposed and ask them to get tested. Decentralized models like the one that have been built by Google and Apple don't have a centralized reporting mechanism. You volunteer to report your positive status on your app, and your contacts can voluntarily pull their contact list every morning of everyone that they have been exposed to. And if anyone has been marked as positive in that contact list, then you know that you may have been exposed, and you are expected to do the right thing, go get yourself a test or quarantine at home. The challenge with these is that they were based on several assumptions. That people would have access to smartphones, that they would download these apps, that if they downloaded the apps, they would actually use these apps. The centralized models like Arogya Setu, which is the most downloaded digital contact tracing app in the world, the one in India where over 120 million people signed up in the first few weeks, is not very privacy preserving. So it risks privacy because it's highly centralized, but it's epidemiologically, it scores very highly because it is centralized, and it guarantees that your contacts will be notified. Apps like Apple and Google, like Corona Warn on the left of this graph, are very privacy preserving because everything is left up to the user of the app. But they're not epidemiologically very salient because it expects that everyone will do the right thing. Singapore's Trace Together falls somewhere in between. But all of these apps are based on the assumption that enough number of people will have a smartphone, and the math just doesn't work up. In India, for example, smartphone penetration is less than 30%, and studies have shown that for digital contact tracing apps to work, about 60% of the population needs to use it correctly. There are assumptions that most people that have downloaded the app will use the app, and that'll really depend on people's trust in government. Migrants, communities that have not enjoyed the trust of their governments are not likely to report their contacts to the government. What kind of quarantine and isolation results from this testing also determines whether people will use the app. If you are allowed to quarantine at home, you're likely to use this app. If you're going to be yanked out of your home and taken to a public facility, you may not want to use the app. What we found is that when you relax these assumptions, all the apps do quite poorly. None of them really have high epidemiological salience, and some of them, in fact, really risk privacy. And it really came down to understanding access, whether people will have access to the phone and the app, and trust in government. The same lack of context was also seen with human mobility data. Early in the pandemic, we all sort of experienced where we were all exposed to these dashboards that were being pushed out for the first time by technology companies very publicly, based on data from your cell phone location and ad tech data from all the apps that you use on your phone. Companies started scoring people, counties, neighborhoods, cities, based on how they were moving to predict whether physical distancing measures were working in these communities. What these data did not show was the representativeness of the data. Who are you counting? Who are you not counting? Did the most vulnerable communities, the wage workers, the elderly, actually have access to smartphones? Were they on the sorts of apps from which this data was being drawn? Who did you leave behind when you used this data? And most importantly, what did the data mean? Because if you're in a suburb and you're in your car, and even if you travel long distances to go to the grocery store and get your milk, where everyone is physically distanced and masked, according to mobility data, you would come off as traveling long distances. If you were in a dense urban environment, say the Queens in New York, not wearing a mask, traveling very short distances to very crowded marketplaces, according to mobility data, you're probably doing good, but you're probably participating in super spreader events. in order to sort of address these challenges, we realized that it is really important, especially in sort of a new disease like this, when understanding is constantly evolving, to be as transparent as possible. Models that were put up on GitHub, models that were transparently published, were the ones that invited most critique, but also became the ones that were most effective. The COVID-19 mobility network that colleagues and I helped start in collaboration with over 70 researchers from around the world, attempted to serve as a science research intermediary between large technology companies and city and state governments. Every evening, our volunteers would get on the phone with public officials and help help by providing infectious disease epidemiology expertise to these public health officials, help them interpret the data coming out of these technology companies. So yes, you see all this fancy mobility data, but what does it really mean in terms of policy? What we realized through this exercise is that tremendous amount of work needs to be done in disasters, both infectious disease as well as natural disasters, to better our data readiness, to make sure that we understand what these data mean, who they count and who they not count, and who they leave behind, and the differential impact that such skewed data can have. We also understand the challenges behind developing analytical tools for these novel data streams that no one has really worked with in the past. And finally, the challenge of translating these data to public health agencies, which has only just begun. So even if you have the right data and the right analysis, how do you build the local capacity within public health agencies to respond to these data? To do so, COVID-19 Mobility Network has now evolved into a university-wide platform at Harvard in collaboration with the humanitarian agency Direct Relief called crisisready.io. We're looking at the application of open DP tools, so differential privacy tools, to these very large data sets so that they can be more widely available to a larger community of scientists to collaboratively around the world figure out the methods that we need to strengthen this analysis. We will be applying these methods to understanding population displacement and health system needs with the California wildfires, and continue to do our work with the COVID Mobility Data Network. Thank you for listening. I'm happy to take a few questions over the last couple of minutes if there are any.
Thank you.